Dr. Alok Gupta ji, Dr. Yogesh Parekh ji,
Thank you, sir. Good
dear
evening.
Professor Singarvelu, our National President, most welcome, sir. Dr. Singarvelu, sir.
He is muted.
Right. Nice that, Dr. Tilak, welcome.
The neonatal transport was very good, sir. All the
Sir?
three speak. Yeah. Yogesh ji.
Pardon, sir?
Yes, sir.
Yeah. The transport, neonatal transport
Sir, yes, sir.
discussion.
Yeah. Very good, sir.
Good evening, Ramakrishna sir. Good evening, Alok ji.
Very good evening, sir.
Vijay
Very
Kumar
good
sir.
evening.
Good evening.
Good evening.
Good
Honored
evening,
to have you
Singarvela.
here. Right. After a hectic Sunday
Good
yesterday,
evening, Yogesh sir. Good evening. All. Good evening to all.
Sir, sir.
I know you were busy yesterday in Coimbatore. But
Yes,
still
sir.
you
Yes, sir.
Thank you, sir.
Even now, there's another meeting, sir, but I want to join.
Naturally, it will go on. It will be going on. Nice that you have joined. Thank you, sir. Today we had a hectic day for our undergraduate exams. So, ma'am.
PG exam, huh?
Dr. Singarvelu, sir, yesterday's meeting was successful, I believe.
Yeah, in Coimbatore, yes.
Right, sir. Yesterday there was a meeting. I couldn't make it because we are in the midst of exams. Good evening, Bala sir. Most welcome. Yes, Dr. Ramchandran, today's mentor, is taking some time. He'll be joining shortly. After that, we'll start meeting.
Sure.
is Dr. P. Ramchandran from
Ramchandran
SRM,
Chennai.
Chennai. Good
Yeah.
evening, Dr. Bala sir.
Good evening,
Most
good evening,
welcome.
good evening, Alok and
Good evening, sir. Good evening.
Lokesh.
Good evening.
Yeah. Good evening, sir.
Good evening.
Bharat.
How are you all?
Good
Sir.
evening, Dr. Balasubramanian, sir.
Sir,
Good.
namaskaram, sir.
I thought you're blessing me and you're saying namaskaram.
Namaskaram, sir.
Yeah.
Sir, we will wait for some 3-4 minutes. Dr. Ramchandran is yet to join. He's busy. So that's the time we are taking.
If the PG has joined, you can demo.
Not yet. Both
Not
have
yet.
not joined.
Oh.
So we just
Okay.
have to wait.
Sir, good evening, sirs. I've joined, sir. Sir is yet to join, sir.
Yeah. Student is here. Sushil is here.
Best wishes, Dr. Sushil.
Yeah.
Thank you, sir.
We hope to learn a lot from the presentation and gifts.
Yes, sir. Hoping to get a lot more inputs from all of you, sir.
Ramakrishna, sir, you are muted.
Right. Dr. Sushil, before Dr. Ramchandran joins, you may share the screen once for rehearsal and just stop sharing.
Okay, sir.
Right.
Just for your confidence. You can do, but still.
It is better to have a check with the internet connection.
आपके द्वारा डायल किया गया नंबर अभी व्यस्त है कृपया कुछ समय पश्चात प्रयास करें नंबर
Welcome, Dr. Sitaraman, sir.
Good evening, Dr. Sitaraman, sir. Good evening, Sitaraman, sir.
Sushil, you are trying to share it? Okay.
Yes, sir. Yes, sir.
Good evening to all, sir. Good evening to all.
Good evening,
Good
good
evening,
evening,
sir.
sir.
Good
Just
evening.
please stay
Hi.
back for just it for 5
Good
minutes.
evening.
For 5 minutes. Right. May I request our National President-elect, Dr. Professor Chengarvelu, to give his opening remarks for this session, sir.
Thank you, sir. Thank you, Ramakrishna, sir, our national convener and a person who is doing extremely well for our postgraduates for over a period of, I can say, in decades. And I am sure that under your leadership, this program will go on very well because all stalwarts, starting from Srinivasan sir, SBS sir, and all my close friends and the great academicians are there to support it. And today's being our PRC sir, a great Dian of pediatrics who has been having extraordinary knowledge, who has been in Institute of Child Health, one of the premier institute in Chennai, among which is very well. He was there as a director also. After that, retiring from there, he is continuously working as a research person in one of the prestigious university in Tamil Nadu, Ramachandra University. So his rich experience and the student who is going to present today will be great learning experience, not only for our postgraduates and practicing pediatrician. And I want this program to be very interactive because all learned people have joined here. So we can also interact so that PGs will learn a lot from this. So nowadays, I can see what we were there in our younger days, and now the situation of cases in colleges and students' exposure is very much limited. So this type of program will definitely make them to learn a lot. I wish a happy learning, and thank you for giving me this wonderful opportunity, Ramakrishna sir, and to our president Neelamohan, secretary Ruchira, and our immediate past president Vasant. All were doing extraordinarily good work. So this program will continue in future also. Wish you all a happy learning. Thanks, sir. Over to you, sir. Over to you.
Thank you very much for joining and giving the wonderful message. And I think Dr. Neela Mohan has not joined. Ma'am, have you joined? I'm not seeing you. Okay, as and when probably she may be busy.
Ramakrishna sir, sir, this is a academic program. You go ahead, sir. Whoever is there,
Right, sir. Right,
academics
sir.
is important.
Right.
Neelam
Right.
also will not mistake. Nobody will
No.
mistake. It is not to project ourselves. You wait for a time. Whoever joins, you can just say for 1 minute. Otherwise, you go
Yes,
with
yes,
the
sir.
subject, sir. You can proceed,
Nice
sir.
of you,
as you
sir.
wish.
Nice of you, sir.
Thank you.
Thank you,
you.
Dr. Singarveru, for joining
Thank
us and giving the message. I take the privilege of inviting Professor, Emeritus Professor Dr. P. Ramchandran. He is MD Pediatrics and DNB Pediatrics. He is Professor Emeritus and Pediatrics and Head Divisional Clinical Research Division, Head Bioethics, SIR HER, Chennai. He was Editor-in-Chief of ACH, TNSC, IJPP between 2014 and 2016. And he was convener and IAP HOD Professor Cell from 2013 to 2016. And his areas of interest, critical care, infectious disease and nutrition. Above all, he is a nice gentleman and a wonderful academician, and expecting a lot from you, sir. All of you will learn from you, and we will start. And I request the stalwarts in the on the screen, like Dr. SBS, to share your knowledge as and when you deem fit. I need not invite, sir. Thank you. And Dr. Ramchandran, please take over. And Dr. Sushil, you may start sharing the screen and make it full screen. Okay, wish you all the best. You can do definitely wonderfully under the guidance of mentorship of Dr. Ramchandran. We'll start it. Professor Ramchandran, you take the center stage. Professor Ramchandran. Sushil just has
Yes,
not
sir.
joined.
Hello, sir.
Hello.
I'm
Professor
sharing
Ramchandran
my
joined?
screen.
No. He has not joined yet, is it?
I'll.
You make a call.
Yes,
I
sir.
called him, but you also make a call. Tell him that we are ready. Has he responded? Dr. Sushil?
Not yet, sir.
Sir, it is better you can go ahead, sir. As the singers are young, so better you
Right.
should start.
Audible?
Yes, sir.
Joined?
There, sir.
Okay.
Dr. Ramchandran joined?
Can we start, sir?
Yes, 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 yes.
Sir.
Yes, sir. Most welcome,
Yeah.
Professor Ramchandran. We are
Yes.
waiting for you to get enriched
Right.
with your knowledge and wisdom. Right, we'll start, sir.
Thank you.
Right,
Thank you,
please, you go ahead.
Sir.
Welcome, PRC, sir.
So,
Welcome,
all
sir.
the
Welcome to you, sir.
thank you, sir. Thank you, sir. Thanks for your gracious presence and also Professor Yogesh Parekh. So I'm just seeing both of you. Thank you, sir.
Srinivasan.
Thanks, Professor Ramakrishna, for this opportunity. Thanks for this opportunity. So for myself and Dr. Sushil, who is our postgraduate from Sri Ramchandra Medical College, Porur, Chennai. So this is college where I've been there for nearly 50 years. So we are happy to present this case and take the discussion in stepwise, so that it will be a good learning experience for both of us, both the listeners as well as myself. So at any this thing, probably if you want, we can give some pause at the end of some phases like a history, so that any queries, anything at that point of time also can be asked. So generally, I presume that the questions will be put up in the chat box. So probably if they are put up, any clarifications, any questions, any comments are put up. So we will try to discuss from that.
I take the
So thanks once
opportunity to
again
thank
for
Central
IAP.
IAP, Professor Dr. Neela Mohan, for accepting the proposal of conducting the PG teaching sessions. I immensely thank Dr. Neela Mohan and Central IAP for the opportunity given to all of us. And I encourage all the postgraduates to participate in the discussion. You should not be one way. You should not be monologue. You put the queries, answers as and when asked for the questions, and also you may unmute and discuss. Okay, right. Sir, we'll go ahead.
Yes, sir. So I'm really very much impressed, and it's inspiring to see all the senior people. Okay, in spite of their so many commitments and other things, they want to be part of this educational program, so that our PGs are constantly encouraged. Thank you so much, sir. Thanks, Central IAP, for this opportunity, and thanks, Professor Ramakrishna. We can start, Dr. Sushil.
Yes, sir. Yes, sir.
You take the case slowly, so
Okay,
that at each point of time, each slide, if there is any clarification, anything, we can clarify then and there, if any point. Otherwise, we can take 2 or 3 slides at the end of it also, we can discuss. So we will look at the slides and then decide.
sure, sir.
Please go ahead.
Okay. Good evening to all the esteemed dignitaries present in this meet today, and I see this as a great opportunity for myself to learn more on this topic as such. So, without much further ado, I'll start presenting my case. So, this is a 2-year, 9-month-old male child who is hailing from Tirupati, Andhra Pradesh. The informant was his mother, and he was the firstborn child of the family. Date of admission was on 29/4/2026, and the date which examination took place was on 30/4/2026. So, chief complaints: the child presented with complaints of.
I will just stop at this point, Sushil.
Yes, sir.
It is very important to mention these things, because in the exam sometimes,
Yes, sir.
when you are presenting a child who has been admitted in the hospital 10 days or 2 weeks before,
Yes, sir.
the presenting symptoms and the present symptoms when you are presenting in the examination may be different.
Yes, sir.
So you can make it very clear upfront to the examiners that what you are presenting is as and when the child came,
Yes, sir.
so that they also get a good idea about how the child presented with, and how the whole problem has either progressed or improved. Okay, so it's a very good way of starting. Okay.
Okay, sir. So,
And generally, it is
yes, sir.
also, since you are telling very clearly about even the months, it is a good thing. Otherwise, you can mention about the date of birth also, because
Yes,
some of the parents, our parents, they may make some may not be very accurate in the calculation of the age. So also we can always tell the date of birth also.
Okay, sir.
Please go ahead.
So the child presented with chief complaints of decreased movement of the right upper limb for the past 5 days and difficulty in walking for the same 5 days, with associated with decreased speech output along with deviation of angle of mouth to the left since 26/4/2026. And along with this, the child was also noted to have decreased activity for the past 1 week. Coming to the history of presenting illness, this 2-year, 9-month-old male child presented with history of inability to effectively use the right upper limb since 26/4/2026 upon waking up from sleep at around 7:30 a.m. in his own residence, which was acute in onset. So from this point on of time, so the child was preferring to use his left hand, and the weakness was improving over the past 5 days according to the parents' history. And then there was a history of difficulty in walking for the past 5 days, which was in the form of dragging of right foot, which is also improving in nature. Currently, the child is able to lift both the legs and walk normally at the time of examination. There is history of deviation of angle of mouth to the left, which was noted on the day of the start of insult. And according to the parents, there was no history of drooling of saliva from the right side. The child also had history of decreased speech output, which was noted on the same day, 26/4/2026, which gradually improved till the date of admission to SRMC. And the child also had normal comprehension. So these were the positive findings which were elicited. Coming to the negative history, the child did not have any history.
Can we
Yes, sir.
stop here?
Yes, sir.
Just
Yes,
to
sir.
discuss
Yes, sir.
a few things
Yes, sir.
regarding the
We will
positive
start the positive
history.
findings.
Yes.
Discuss.
Yeah. So you are presenting a child who is 2 years, 9 months old,
Yes, sir.
who had an onset of illness about 5 days before he came to the hospital. Am I right?
Yes, sir.
Okay. And the main presenting problem was the weakness of the right side, both upper limb and lower limb,
Yes, sir.
which the parents noticed when the child got up in the morning.
Yes, sir.
Right. Okay. So how was it? He was not able to lift the upper limb above the head or something, or he was just using it less. Anything specifically they are able to say that regarding the how much was the weakness? Any information we are able to get?
Yes, sir. Upon further probing, the father was able to tell that the child had vibrations like tremulousness of the hands when asked to lift the hand. And after that, slowly bringing him to the hospital and all, he started moving to a better extent than what it was upon waking up, sir.
It is. This is you expand more on the
Yes, sir.
positive history. How the problem was, how it started, how acutely it started,
Yes, sir.
and what is the extent of the problem, and then how it improved as per the parents' observation. So instead of just telling that the child became better, you tell us in terms of on which day they noticed the improvement, the very same day evening or the next day or the 2 days later, because that may give us some clue regarding the what is the likely problem, underlying problem.
Yes.
Okay.
So,
So can you just tell us something more?
Yes, sir. On the day of the weakness, the child was immediately taken to a nearby clinic, sir. Over there in the clinic, they had referred them to Tirupati Hospital. So by the day 2 of illness, the child had improvement in the weakness of both the right upper and lower limbs. Predominantly in the right lower limb, his weakness was getting way better, sir. Child was starting to walk, and the right upper limb weakness still persisted in the distal muscles, but child was able to lift his hand and like up to his shoulders is what the father told us. So by day 2 of the illness, the child was starting to improve, sir.
Okay.
Dr.
So,
Chakravarti,
Yes, sir.
sir, please go ahead.
as Dr. Professor PRC was telling, you have focused more on the positivity. See, you are talking more about the recovery than the how the events have deteriorated, progressed. Okay, the weakness, what is the progression? And instead of saying day 2, you say how many hours. Why I'm particular about hours? Anybody would like to tell? Any postgraduate or Dr. Chakravarti?
Sir, the etiology, possible etiology, sir. If it is ischemic, the child will have progressive loss of the ability to move his hands, and embolic, sir, acute presentation. And
One thing is, you have to talk about the progression of the positive symptoms more in detail, as Professor PRC is telling.
okay, sir.
Then why I am so particular about hours? After which the improvement started is,
What will you think
there are
of?
one condition
Yeah.
which improves within first 24 hours.
Sir,
Hours.
Todd's palsy, sir, post the
Todd's palsy. See, why there is no setting for Todd's palsy. There is one condition which is exactly like this, but the recovery occurs within 24 hours. Generally, few minutes.
transient
Dr.
ischemic
Nandini, you are right, it is
attacks.
TIA, transient ischemic attack. First of all, you say whether it TIA or full-blown stroke. Dr.
Okay,
Mehra, you
sir.
are right. So
Okay,
that
sir.
the concept of TIA is different and the presence of stroke itself. So you have to differentiate whether it is TIA. That means the recovery started within hours. See, they may be vague in saying by second day the child has went. So the treatment of TIA differs and the treatment of stroke differs. Okay, that you have to differentiate. Secondly, you are more focused. Like, please don't get hurt. It is not to hurt you, because whatever you tell, it is followed by hundreds of postgraduates. Okay, not to hurt you. If I were in your position, I would have done better than you. Okay, you are not talking about the trunk, axial muscles, neck. See, it's not the weakness, is not confined to upper and lower limbs, isn't it? Because
Yes,
that is obvious the parents are talking. So you have to comment about the involvement of the trunk, like sitting from the supine position to sitting, from sitting position to supine, and moving the neck this side and that side. That is also part of the central nervous
Yes,
system, isn't it?
yes,
That
sir.
is to be added. Not only you, 99% of the PGs talk about limbs only, as if CNS supplies only limbs. Okay, never forget involvement of the axial muscles. Okay, these
Okay,
are the two my observations. Dr. PRC.
And it's also, when you're talking about the change in the symptoms or progression, you cover all the aspects. You mentioned about the lower limbs, you mentioned about the upper limbs, you also mentioned about the deviation of the angle of the mouth,
Yes, sir.
whether that also improved, okay,
Yes,
and how much time it took. So, point which is emphasized is, you tell more about what actually happened to the child rather than what did not happen.
okay,
And the timeline of events, how it happened, how it improved, how many hours it improved, okay, or how many days it improved, and how much it improved. Was it totally, completely normal, or some residual, some weakness?
okay,
Okay,
sir.
instead of getting fully normal, they were quite happy that child was able to walk, but the
Yes, sir.
child might have been dragging the foot,
Yes, sir.
or the child might be using the limb, but may not be that powerfully. Okay,
Yes, sir.
or might be still preferring the other limb,
Yes, sir.
right? Like
Yes,
this, whatever the observation, it's very difficult sometimes to ask these things, but it is in your interest to get all this information from the parents,
yes, sir.
so that we'll know exactly how the disease is or the problem is progressing or improving, or it is only static. Okay,
Yes, sir.
yeah, that
They
gives
are
us a good
focusing on
idea.
improvement because they are happy with that. They are forgetting the bad thing and happy with the jubilee. Right. That's why they are not focusing. You focus it. Right. Next
Okay, sir.
slide.
Go ahead.
Yeah, anything on the speech?
Yes, sir. The child had decreased speech output, sir.
No,
But
I think you have to be more specific, because this is a 2-year-old, 9-month-old baby. And you
yes, sir.
have to know what exactly he had achieved before he had this.
So before
And
this,
had
yes, sir. Before this, the child was able to speak 2 to 3 word sentences, sir, and also was able to indicate its needs. Like if he wanted water, he was able to say water, glass. So these things, the child was not communicating to the parents when prompted, sir. But
communication or articulation?
articulation, sir. But
So,
yes, sir.
what sir is asking probably is whether the speech output decreased, or it totally stopped, or there is no clarity of speech.
No, sir. The
Yeah.
speech
Was it
output.
dysarthria or dysphasia or aphasia? So
Exactly.
can you make that distinction?
Yes, sir. It was distinct. Like aphasia was what I could get from the history that the father presented, sir. Because on indicating water bottle, he was telling that he wanted to drink, but then he wasn't telling it as water like how he used to before, sir. This was what
Okay.
they told, sir.
Okay.
Why
So
Professor
each
Sitharaman is
of
so
this,
particular about the type of speech affection?
Sir, the cortical
Yes.
motor
To
aphasia
know the level of the involvement of the level,
lesions.
at
Yes, sir.
what level the involvement has occurred, speech is a good indicator. As Dr. VRC is telling, whether it is aphasia, dysarthria, like that, that tells the level at which you can know what exactly the anatomical level to some extent. Right. Proceed.
okay.
Yes, sir. Moving on to the negative histories, the child did not had no history of loss of consciousness, altered sensorium, seizures, any behavioral changes, memory or emotional disturbances, and there was no history of disturbance in perception of smell, visual dysfunction, double vision, squint, inability to close his eyes, decreased taste sensation, hearing disturbances, vertigo, any nasal twang to the speech or regurgitation of food or any dysphagia history. There was also no history of any alteration of sensations or loss of sensations during this period. And he had no gait abnormalities, no history of swaying while walking or any change in handwriting, the scribbling or tremors. There was no history of pain in the back or any spinal deformities at this point of time, sir.
So just stay here.
Yes, sir.
No, go back. Go back.
See, whenever you are telling the negative history,
Yes, sir.
there will be always questions why you are asking this negative history.
Yes, sir.
Okay, because generally, whatever happened, you have to give more time, more importance, and what did not happen should be more focused. It should really tell you or to rule out certain things, okay, or
Yes.
identify some very specific problem. So whenever you are telling this negative history, questions will be asked. Any reason you are asking about the first negative history regarding the altered sensorium, seizures?
Yes, sir. I'm asking particularly on the higher mental functions at this point,
No,
sir, to rule out
no. Sir was telling, does
level
it
of
give you an idea regarding the
level.
localization,
Yes, sir.
the problem?
Yes, sir. Cortical
Yeah, I
involvement.
mentioned that.
Yes.
Okay, instead of saying higher mental function, you say you are looking whether there is a cortical involvement, clues as for a cortical involvement, correct?
Yes, sir.
Okay. The next one, what is the reason for asking about visual dysfunction, double vision?
Sir,
So,
any
how do you expect a 2-year, 9-month-old child to tell about double vision?
double vision if the parent.
So, be very practical and ask things which a child will be able to express. Okay.
Yes.
You need not cover everything which is given in the book or in some of these guidelines. Okay. You ask, think, and whether the child will be able to say all these symptoms, you ask only those things. Okay.
Yes, sir.
Because the child is only 2 years, 9 months. So
Yes,
you'll
sir.
have to understand that. Okay. So
Um,
you are telling visual dysfunction. What are you expecting actually?
Sir, to look for any cranial nerve involvement, sir, and depending on what cranial nerve is involved, we can localize the level at
Okay. Inability to close the eyes. This question was asked for what purpose?
Sir, inability to close the eyes to look for the third cranial nerve palsy, sir. 3, 4, 6.
Okay. This child has got a
He is
deviation of the angle of the mouth to one
Yes, sir.
side,
Yes,
isn't
sir.
it?
Yes,
So
sir.
what did it indicate to you?
Sir, 7th cranial nerve involvement and
Okay. So does it help this question? Does it help you to identify anything regarding the 7th cranial nerve?
yes, sir. It was only the angle of mouth deviation was there. So lower half of face on one side. So probably
Right.
an UMN involvement, sir.
Right.
Of
So you tell that instead of
Yes.
telling third now, it's mainly useful to help differentiate. That is a question you are asking. So
Yes.
like this, the individual symptoms may be picked up and you may be questioned. Okay.
Okay.
So give your negative history, make it very focused and what is going to help you pertaining to the presenting symptoms.
Okay, sir.
Okay, right.
See,
Chakravarti,
Yes, sir.
absence of seizures and altered sensorium broadly rules out which scenario?
Encephalopathies or any
No. See, in
meningitis.
this given, see, this is hemiparesis.
Yes, sir.
Most of the encephalopathies, they don't lead to hemiparesis. It is not a hyperacute
Post-
presentation. It may not be arterial hemorrhage.
Okay, sir.
Okay, that is hyperacute, associated with altered sensorium, and most of the times seizures.
Okay, sir.
When they are not there, yes, speech is involved, maybe cortical, but it is not extensive because there is no altered sensorium, there are no seizures. Okay,
Yes, sir.
right. Next.
Just a
And
minute.
Yes,
I-
sir.
what
I
is it?
think,
Why do you want to put this question of say this no history of swaying while walking, change in handwriting?
Sir,
You are telling us this child had weakness of the upper limb.
yes, sir.
Do you expect the handwriting to be as good as before?
No, sir. In this
No.
scenario,
That's why you apply your logic. Okay, so when you are asking or telling these things, okay, what you may not be able to clearly understand, tell, you don't have to implicate yourself unnecessarily.
okay, sir.
I think, Sushil, you have to temper your history according to the developmental age of the child. You
Okay,
don't expect a 2 year, 9 months for change handwriting.
Yes, sir.
You may not, the child may not be able to tell anything about sensations. So you have said no issue of loss of altered sensation. That's a very subjective feeling.
Okay, sir.
And as Dr. PRC has already said, that visual dysfunction and all has to be tempered with the developmental age of the child.
Yes, sir.
Any history is to be elicited in the context of the age and in the context of the development of the child.
Okay, sir.
Okay, a child who cannot walk at 3 years is significant, and a child who is not able to walk at 1 year is different. Okay, even though the complaints are same, right? Okay, next.
The child also did not have any history of headache, vomiting, dehydration, or trauma, or ear pain, ear discharge, or any example.
Your slide has not changed, I think. I am seeing the same.
No, sir.
Oh, sorry.
It's
Yeah.
another.
Yeah.
It's
Okay, go
another.
ahead.
It's another.
Sorry, it has changed.
No issues.
My
Yes,
fault.
sir. Child had no history related to any increased ICP intracranial tension features or any recent trauma or any ear infection, sir. There was also no history of any exanthematous rashes. And child had no history of any palpitation, cyanosis, cough, or related to any cardiac issues, and also no history of long-term foul-smelling sputum, orthopnea, or any bleeding tendencies, sir. Essentially ruling out any chronic lung diseases or bleeding diathesis. Child also had no history of pica, sir, according to the parents, ruling out iron deficiency anemia, and also no history suggestive of static encephalopathies, sir, like such as cerebral palsy, sir.
By this, you think that there is no it is not complicated by raised intracranial tension. Okay.
Yes, sir.
And why did you ask for dehydration?
Sir,
It has
dehydration.
relevance, but what is that?
So dehydration can predispose to prothrombotic events, sir.
Severe dehydration.
severe
Severe dehydration.
Yes, sir.
Yes.
So,
And,
instead of dehydration, if you had asked about vomiting and diarrhea, that should be probably sufficient in the history.
Okay,
The
sir.
parents may not be able to tell you about whether a child was dehydrated. Okay.
Yes, sir.
So tailor your questions as per what will be given by the parents.
Okay, sir.
yes, Dr. Ramya, you are right. It is cerebral venous thrombosis. Sinovenous thrombosis may result. Yes, sir. Proceed, Dr. Chakravarti.
So the child was
Just a minute. Just
Yes.
hold. Comments from Dr. SBS.
Yeah.
Dr. SBS.
Few comments. One is that I think I want the student to stress whether this child was normal or apparently normal before the onset of the illness. I think you should have started. It's always a good habit for the students to say something about how the child was before the onset. For example, this child who has had something like weakness of limbs of sudden onset, if there had been a background of some chronic illness in the past, instead of saying in the past history, in the history of present illness itself, it would be a good habit to start saying that this 2.5-year-old who was well, okay, apparently well or well, with some adjective, with some proof that this child was well compared to the peers or somebody, indicating that everything was normal before this. Otherwise, that is not captured. That is not captured. If the child had not been well before this, your differential diagnosis is different. Your child is completely well just before, the differential diagnosis is very much different. And again, already stressed, I don't want to repeat it. I think palpitations, headache. I have not seen a child with 2.5 years with headache. I have not seen a child 2.5 years presenting with palpitation. All this, you should simply don't, there's a book called French Index of Differential Diagnosis, old medical book, a fantastic book. For every symptom, it would give 100 differential diagnoses. And remember, in the past history, you need not look at French Index of Differential Diagnosis and give negative history for all the 100 conditions you know of or which can cause a similar illness like this. Make it sweet and short. For example, where is the question of foul-smelling sputum in a 2.5-year-old child? I have not seen a single child at 2.5 years with foul-smelling sputum production. It doesn't happen, right? And again, don't use words like no history suggestive of static encephalopathy. That's not correct. You are expecting the parents to make a diagnosis of static encephalopathy? No, right? So instead of saying that, you should have stressed that everything was fine with this child, with some adjectives, with some comparison if there is another sibling, something like that. That's my humble suggestion. Otherwise, this history is fair enough. And one other point that was missing, I thought, you said deviation of the angle of the mouth. You didn't mention. I'm sure the parents should note whether it is right or left. Did you ask that? That's important. Well,
Yes.
that will tell me if there is from what you're saying, it looks like a hemiparesis. I would like to know whether it is a crossed hemiparesis. Facial weakness in the opposite side or same side will make a lot of difference to the localization of the lesion. That's very important. You simply said deviation. You did not say deviation to which side. That's very, very important. Okay, these are my comments. Otherwise, a fairly good history.
Right.
Please don't get rattled.
Yes, sir.
Just for completion, make it more brief, more brief. So many negatives need not be there.
Okay.
Can I make a remark if you don't mind?
Yes, yes, sir. I am about to
One
call you.
One more is that you could have mentioned whether the parents found the limbs to be floppy or stiff.
Yes, sir.
That also is important. Of course, you don't expect hemiparesis like this to be lower motor neuron. At least if this disease is severe, there may be floppiness, which is quite obvious in the early stages, followed by spasticity later. So that perhaps might have been very appropriate. And you don't expect a 2.5-year-old child to do handwriting, to talk about
Yeah.
handwriting.
Yes.
Handwriting.
One more point I wanted to mention.
Yes.
Asking too many questions will disturb the parents much further.
Absolutely.
Unnecessary questions. Yeah, because they will think that a child is likely to get all these things. So unnecessarily must not probe into so many unwanted questions.
Yeah. One more comment in a lighter vein. At least 3 or 4 times, the presenter went on saying, as per the parents, as per the parents. As an examiner, if anybody says as per the parents more than once, that means the candidate is not confident. Don't say that. You
Okay.
must also know our parents don't attend CMEs, don't attend webinars to give correct history. So give allowance for them. So don't say as per parents. Everything is only as per parents. Okay. Thank you.
Okay. Okay, sir. Thank you.
Dr. Vijay Kumar and Dr. Tilak Chandra Pal, any comments briefly? Okay. Proceed, Dr. Chakravarti.
Post this, the child was evaluated in Tirupati with where neuroimaging done was found to be abnormal, and they had told that it was some vascular etiology. And the child persisted to have weakness of both the right upper and lower limbs at this point, but severity was improving in nature, and no other significant events were noted in the hospital. Blood investigations done at that point of time were within normal limits, and the child was further referred to a higher center, citing the nature and urgency of the condition, sir. Coming to past history, the child had a history of one fever spike on 23/4/2026, which was 3 days prior to the onset of weakness. And this was treated on OPD basis, and the fever had settled within the same day. No further spikes were noted. And then one significant history was the child had history of varicella infection in January 2026. This was conservatively managed at home, not hospitalized, and the child had recovered well. There was no history of use of any antiviral drug during this time. And otherwise, there was no history of similar complaints in the past, any seizure history or any head trauma or ear infection or a heart disease. And there was no history of any previous hospitalization or surgeries done, sir.
You would like to give some relevance to varicella infection?
Yes, sir. So this infection had happened within like 2 to 3 months prior to the onset of the weakness, and so this is a important clue for one of our differential diagnoses. It could be varicella-induced angiopathy, post-varicella angiopathy. So we can evaluate on the grounds of that, sir.
Yes. Dr. Ramya, you are correct. It is varicella arteriopathy. But Chakravarti, how long that is relevant?
So
How
12
many
months, till 1 year, sir, till
Good,
post.
Good. Yes, proceed.
Generally, how do you ask the question for varicella?
Sir, the presentation, sir, fever with rash involving.
Is a fever a must in varicella?
No, sir. Could,
Okay, it can be present. Usually a low-grade fever. You're right.
yes, sir.
Then,
Sir, in some cases, even without rash, the child might have got varicella, sir.
no, that is very difficult for us. Okay, you tell us. Typically, what will be the these are all the simple things, no?
Different,
The usual things which are
yes, sir.
asked in the exam.
Different morphology of the rash.
Also, sometimes the parents, for the parents, everything is some mata, ramai, or whatever it is. Okay, so
Okay.
you should ask some questions, leading questions, to make sure. So generally, what will be the type of presentation? What other clue you may get? Okay, to think that it is probably an exanthematous fever like varicella. So you just tell us 1 or 2 points.
And actually, it's also important to realize that when it's such a varicella infection, very definitely they give it. Just ask them, they have got it confirmed with the doctor.
Yes, sir.
I know, because it may or may not be there.
Yes,
It will
sir.
only prove your point. And moreover, in the history of fever, if one spike at 23rd, what was the medication given should also be written down out here.
Okay, sir. Sir, for that one spike of fever, they had just taken an oral paracetamol, sir, syrup, just 1 dose. Post that, they didn't have further spikes, so they didn't give further medication. The varicella infection, as it's, we can reconfirm by the morphology of the rash, or like different points of time, the eruption and the crusting of lesions, and involving the trunk, sparing the extremities. Those leading points we can ask, sir.
Okay. Another important thing in varicella and measles is also contact you can ask. Usually, you will get a history that multiple people in the vicinity or in the family getting the similar rash. That also may be useful for you, especially if there are other children also. Okay.
Yes.
Fine.
So,
to
yes, sir.
save time, to give
Yes.
more time for the neurological examination, we will skip the antenatal, natal, and postnatal history. You shall write in the exam very
Yes, sir.
much, but we started a little late, so we have done good job, but we will skip for this time being. Okay.
Okay, sir.
Right. If
The-
they need
Sir,
more
I'm sorry.
elements.
Sir, I'm sorry. We started late. Huh? I thought it was 9 o'clock.
No, not to cast aspirations, sir. Not that way.
Sorry, sir. My apologies. I thought it was time was 9
not
o'clock.
that way. Not at all. Not at all.
Sorry.
Not at all. Please don't feel, sir. Right. Just I am putting the scenario. Right.
So the
Please don't get offended, sir. Right.
Sir, antenatal and the natal history were insignificant, sir. The child had a clean course, sir. Child was delivered by normal vaginal delivery. Birth weight was also normal, sir. No significant NICU stay or any history of neonatal hyperbilirubinemia. Nutrition-wise, the child was started on formula feeds since birth, and in view of the poor maternal secretions, supplementary feeds were started after 6 months, and the child is currently consuming mixed diet. The calorie deficit was around 130 kilocalories. Protein requirements were met according to his needs. The child also consumes only green leafy vegetables once a week, which was a little suboptimal oral iron intake. Coming to the developmental history, the child, gross motor wise, the child was able to climb up and down stairs on his own, sir, and was able to jump and run. Handedness was noted by the parents at around 1.5 to 2 years of age, and he was said to be right-handed, preferring to use the right hand. Fine motor wise, the child attained circular scribbling, and he was able to feed himself with a spoon. Language wise, the child was speaking 2 to 3 word sentences and also was able to indicate his basic needs. Social wise, the child was playing cooperatively in a group and also was able to dress with the support of his parents. So interpretation is the child was normal, attained normal development up to his age. Immunization history, the child was immunized up to age according to the national immunization schedule. The child did not have any history of taking vaccines according to IAP schedule, sir. Coming to the family history, that they
Yes, watch time.
sorry, ma'am.
On the list.
Not related for us.
Okay.
Right.
Family history, the child belonged to a joint family. First born to a third degree consanguineous marriage. There was only one history of diabetes mellitus in the paternal grandfather. Otherwise, there was no other significant family history relevant to our presentation, sir. No bleeding manifestations or any cardiac history or any early stroke or any similar presentations in the family members. Social economic history, they belong to class 3 according to modified BG Prasad scale. So, summarizing the history here.
Just Dr.
There is no
Chakravarti.
family history of. Sorry. Sir, please go ahead.
No, please tell, sir. Please tell. I'll
For the family history, there was no neurological illness in any of the cousins or the previous generation. Any such thing?
No, sir. I asked them. They told there was no similar.
There was nothing.
Nothing.
Okay. Other than the diabetic history,
Yes, sir.
the parents were totally normal health.
Yes, sir.
Good health?
Good health, sir. There was no comorbidities in the parents also.
Okay, right. So because some of the problems
Yes,
in a given case like this, where you are thinking of hemiplegia,
Yes,
there
sir.
may be some metabolic problems which sometimes you may be able to get some clue.
Yes,
Okay. Sometimes after the problem comes, when you ask retrospectively, the parents will say, yes, we also had did some checkup and we found out that we had some problem. So
Yes,
always it's better to ask. Okay, these things the parents sometimes they may forget. Okay,
Oh,
fine.
okay.
Also, you should ask the history of a death of a young adult, sudden
Yes.
acute death, which will reflect upon some kind of AV malformations which may be there.
Okay, sir.
See, that is one point Dr. PRC has made out regarding the neurological diseases in the family. Secondly, it's a good practice to draw pedigree chart for 3 generations.
Yes, sir.
Even though in
Absolutely.
particular case, it may not be relevant, but still we are students and we are supposed to do in the exams and otherwise also. Right?
Yes, sir.
Right. We'll go ahead.
No, it is quite important in this also. Okay.
Yes, sir.
So, yeah.
Right, sir.
Sir, summarizing the history, this was a 2-year, 9-month-old male child who presented to the emergency department of Ramachandra with history of inability to effectively use his right upper and lower limbs, associated with decreased speech with normal comprehension and deviation of angle of mouth to the left. The child otherwise had no neurological deficits or developmental issues before the current illness, with no other known medical comorbidities. The child has had one varicella infection in the January 2026, just 2 months prior to the current illness. From the history obtained, the child appears to have an human type of lesion involving the pyramidal tract on the left side of the brain, with possible involvement of the Broca's area, with no known precipitating factors except the past history of varicella infection. Hence, I would like to go forward with the examination of the central nervous system itself.
Dr. Chakravarti, you have done a good job in eliciting history. 1 minute.
Yes, sir.
Dr. Bala, for your comments.
Happened from the Andhra hospital to, sorry, sir.
No, please proceed, sir. After that, Dr. Bala will give his comments.
You said things about the Andhra hospital, Tirupati hospital.
Yes, sir.
And after getting, he was becoming totally normal there itself, or there is still some residual weakness. There is a gap with the history between Tirupati hospital. They did some investigation normal. How many days he stayed there, and how many days later he reached Ramchandra? He is doing better every day. Was he improving? And if so, what improvement?
Yes, sir. Sir, they had stayed there for around.
I won't mind even if you had included in the initial presenting history.
Yes,
because when you are examining as on today, you have to tell till today what has happened.
Yes, sir.
That way you get a very good progression of the symptoms, how the child is doing.
Yes, sir. The child was in Tirupati, sir, evaluated from 26th to 28th, sir, morning. And then during that time, the child had weakness which was slowly improving, sir. Not any gradual, not any significant improvement. Just instead of tremorlessness, he was able to lift his hand. Speech was still not good, sir. He was still having very decreased speech output, and the deviation of mouth had settled according to the parents on day one itself, sir. Day one of illness, the child had deviation of mouth. Otherwise, following days there was no such thing noted, sir. He presented to our hospital on day 4 of illness, on 29th, sir. And I had examined him on 30th. At 30th, he was almost completely recovered, sir. He was close to being normal, sir.
Was he given any treatment there, or?
So no anticoagulation was started in Tirupati, sir. He was just on conservative management. The parents told they started only IV fluids, and they told to wait for the investigations and then we'll decide. So that was what I could gather, sir.
Fine. Dr. Bala?
Yeah, few suggestions.
Yes, sir.
One, is this a child who is right-handed or left-handed?
Right-handed, sir.
Yeah, I think that should come first right in the history. If I were you, I would have said this right-handed child presented with right in the first sentence. Or at least in development, I would have stressed that he is a right-handed individual. Why do you think that's important?
Sir, that tells us the primary, the dominant lobe, sir. Right-handed individual, the left hemisphere is the dominant one, and based on that, the presentation and localization we can make, sir.
What about left-handed individuals?
So they're also predominant.
There is a dominant. Which is the dominant hemisphere in left-handed individuals?
Left hemispheres.
No, it's not left. 50-50. Many left-handed individuals may even have a left dominant hemisphere also. 50-50. Yes, and second thing, I want to ask you, when did the handedness of this child get established? I would have definitely mentioned that in my developmental history. And why is that important? No. Which year? That is around 1.5 to 2 years.
Yes,
is
sir.
it normal or abnormal?
Sir, this is normal, sir. If he had
Which is
attained.
abnormal? What is abnormal with regard to handedness?
Yes, sir. If they had noted early handedness prior to.
What do you mean by early handedness?
Prior to 1 year of age, sir, 12 months of age.
What are the conditions in which you get early handedness?
Sir, hemiplegic CP, sir, congenital CP.
Is that the only one? Other than CP, you can't get premature handedness. Anybody can put in the chat box, PGs.
One
What about
PGP
Erb's
says
palsy?
in
What about
paediatric.
Erb's palsy, brachial plexus injury?
Yes, sir.
Yes, yes,
Yes,
or
sir.
no?
Yes, sir.
Or
Trauma.
severe contractures like sometimes, contractures congenital contractures, limb deformities may be unilateral.
Yes, sir.
Okay, that can also cause premature handedness of the other side and not the contracted one.
Yes, sir.
Even following chronic fractures in the upper limb, you can get premature handedness of the other limb. However rare these can be, you have to consider these factors. That's
Yes,
one. Second, the summary of the history, just go back. See, always, in CNS, we say T, N, and S. The cause, nature, and site. The cause is identified by the history. You never have. What is your take on you have said appears to have upper motor neuron lesion involving the pyramidal tract. What is the event which has led to this? What is the etiology?
Vascular. I should have mentioned, sir.
Pardon?
Vascular etiology.
What vascular etiology?
Ischemic, sir.
Ischemic. Due to what? Ischemia due to what?
Sir, I'm from history, post-varicella arteriopathy leading to ischemic presentation.
That you should have mentioned.
Yes,
Most probably, this child has got a post-varicella angiopathy.
Yes,
You use the term angiopathy, which can occur 1 year following, even up to 1 year following varicella.
Yes.
Okay. And which arterial territory is involved in this child from the history?
Sir, the anterior circulation, sir. MCA or
Anterior. What is the difference between anterior cerebral artery, posterior cerebral artery, and middle cerebral artery arteriopathy in terms of clinical manifestations?
Sir, in anterior circulation stroke, we can see the involvement of in anterior cerebral artery. Probably the lower limbs are affected more, sir. According to the motor homunculus.
Okay.
Sorry, sir. Sorry, sir. The anterior cerebral will have.
Where do you get monoplegia in a pyramidal tract, in a upper motor neuron lesion?
Monoparesis in MCA territories.
Okay. Usually this is a dense it looks like a dense hemiparesis with also speech disturbance. This is likely to be in the middle cerebral territory.
Yes, sir.
And again, you could have mentioned again which portions of the limbs were more involved in this child. Whether upper limbs are more involved or lower limbs are more involved.
Yes.
Because if upper limbs are more involved, it would favor definitely an upper motor neuron lesion. That's another thing. You should have stressed that the upper limb is more involved than the lower limb. Okay. And you could have mentioned whether this child is improving, deteriorating, or remaining static. You could have stressed in the summary. What is happening? Is he improving, remaining static, or worsening?
Improving, sir.
Improving. You could have added that. These are my comments. Okay, you could have always, history. Most examiners will stop and what is a sum up and give me a probable diagnosis at this point of time.
Okay, sir.
That too, with regard to etiology, you could have summed up nicely and mentioned. But you had discussed that earlier. It's okay. Please go ahead.
Okay, thank you.
Nice that good number of PGs are posting the answers in the chat, which are mostly they are correct. Good. I invite more and more answers in the chat box, and you can unmute. Take the liberty of unmuting and discuss it. Right. Proceed.
Sunil, do you get any clue from the onset about the type of cause of hemiplegia? So, what are you're saying that it is acute ischemic stroke?
Yes.
Okay. So, what about will you be able to say some likely causes and how will you correlate with the history? What clues you may get?
Yes, sir. In ischemic presentation, the child will in this scenario, upon waking up from sleep, the child had the weakness, and it was progressive in nature at presentation, and it was not sudden, very hyperacute, sir. If it was hyperacute presentation, the child would have possibly had an bleeding manifestation, hemorrhagic manifestation leading to such presentations, or if it is lasting only a few minutes to hours, transient ischemic attacks with the possibility of any embolizer. So from those presentations, would have
Right.
helped.
Right. So also the associated symptoms like seizures or altered sensorium, which are more you will be seen in hemorrhagic stroke rather than in ischemic stroke.
Yes.
Okay. But there can be overlap. It is not 100%, but these are useful clues. Proceed.
Dr. Chakravarti, from the
Yes, sir.
history, is it possible to differentiate whether it is arterial or venous at all? It can be there. It can be cerebro-synovenous thrombosis, or it may be a arteriopathy.
Yes, sir.
Or a arterial thrombosis, right?
So one thing in dehydration, very severe dehydration, venous thrombosis is more likely, sir. From history, we can delineate, and raised ICP features us.
Yes,
In
Bhargavi, you are right. Raised ICP features will be there. The onset will be slow. Right? It's gradual onset. And it will not be classical hemiplegia. See, the venous drainage, sinovenous, right? There will not be classical. And there is no setting for the venous thrombosis to occur in this case. Okay,
sir.
Yeah. Right. Yes, we'll proceed.
Sir has put up a question. Professor Alok, what is the origin of the thrombus? He's asking.
Sir, the varicella angiopathy could cause local inflammation of the tunica media and intima, sir. So that could cause any the narrowing of the vessels or produce any aortic dissections or thrombus formation, sir. So
it can be arterial inflammation and arteriopathy, or it may extend even to stenosis also.
Yes, sir.
In uncommon scenarios. Do you think stenosis could have been there here? Arteriopathy leading to stenosis?
So
Unlikely,
stenosis
because the
and
recovery is so
static.
fast.
Yes, sir.
Right? So fast. Right.
Yes, sir.
We'll proceed.
So coming to the examination, sir, on general examination, the child was alert and playful. He was a right-handed child, and vitals, the heart rate was around 110 per minute. It was regular in rhythm, normal character, had no radio-radial or radio-femoral delay. The blood pressures were in the right upper limb 90-60, and even on the left upper limb 90-60. There was no discrepancy. The peripheral pulses were well felt. The capillary refilling time was also less than 3 seconds. Temperature measured at the time of examination was 98 Fahrenheit. There was no pallor, icterus, cyanosis, clubbing, or edema or lymphadenopathies. The attitude at the time of examination, the child was comfortably sitting on his mother's lap, sir.
When you are taking the vitals.
Yes, sir.
Okay. So you are taking blood pressure to find out any hypertension or anything?
Sir,
that idea?
No, sir. In aortic dissections or any aneurysm, there will be variance in the
right.
side.
So the child has got hemiparesis or hemiplegia. Will you take blood pressure in that limb or on the normal limb?
In the normal.
Why? What is the difference?
Sir, thromboembolic could be the right side.
You mean to say the right side, the thrombus is gone and sitting there? Right upper limb.
No, sir. Weakness.
See, there are a lot of vascular changes secondarily which occur in the weak limb. May not be so acutely, especially if it's been going on for a longer time, 2 weeks or 3 weeks.
Yes.
Okay, you may actually see vascular changes. You may see some higher blood pressure. You may actually even see the limbs may be colder compared to the other normal side. Okay, so generally, all these measurements which you are taking for general purpose, you take it in the unaffected side.
Okay, sir.
Okay, that is better. Yes.
Okay, sir.
You may write as lie and attitude. Lie, the way the child is lying. When
Okay,
it
sir.
is in the lab, you may put the heading as lie and attitude. Okay. Right.
Okay, sir.
Proceed.
On head-to-toe examination, the child had no dysmorphic facies. The BCG scar was present in the left upper limb, sir. The child had no external injuries or any intraoral injuries. There was no neurocutaneous markers or no obvious external arteriovenous malformations noted, sir.
You enlighten me on the last sentence, why you have mentioned it. You have rightly mentioned, then why you have mentioned to enlighten all of us. You have rightly mentioned it is.
Yes, sir. In case if we see any external AV malformations could provide us a
Yes.
clue of any internal malformations also, sir. So we have to evaluate for those, look for those in particular.
Good. It will give some clue for the etiological, right?
Yes, sir.
Good. And
Can you have-
Dr. Barney says about neurofibromatosis hypothesis. That also is one thing you have to
Yes, sir.
consider.
Any pigmentary indications of varicella infection?
No, sir. His lower limb had hyperpigmented healed lesions, sir. Sorry.
No, not related to us. You proceed.
And the lower limbs, there were hyperpigmented healed lesions, sir, probably indicating.
Sir, he did have some this thing, sir, pigmented scars even on the trunk, sir.
Yeah, I mean that's why
It
you
has
can actually reconfirm that the
Yeah.
child had
Yes, sir.
varicella.
Yes, yes. He does have.
Right. I think we will proceed. Right.
The anthropometry, the child's height was 96 centimeter between 0 to +2 z-score. Weight was 14 kg between 0 to +2 z-score again. His weight for height was between 0 to -2 z-score. Head circumference came to 48 centimeter, which was 0 to -1 z-score. Mid-arm circumference was 13.5 centimeter, which was between -1 to -2. The interpretation was normal for age, sir.
It's a well-thriving child.
Well thriving, yes, sir. Well thriving.
The growth is normal, had been normal, and development is also
Development is also
well-thriving child. Okay,
Yes, sir.
good. So always we just make it a habit to analyze either vital data or anthropometric parameters. What is your inference that you have to tell, not simply telling the measurements. We are not telling just to measure and leave it there. You have to analyze both vital data and anthropometric parameters. But actually, it is a good habit to plot the growth charts also.
Yes,
I
sir.
understand with single measurement you don't get much information, but still it is useful. Okay,
Yes,
at
sir.
least for exam purpose also that is required. Okay.
Yes, sir. So coming to central nervous system examination per se, the higher mental functions, the child was conscious, alert. He was oriented to person, sir. Time, morning. Speech, the child was able to comprehend well, sir, but there was a decreased vocalization noted even at the time of examination, sir.
You don't expect him to talk to you so freely, no? You are just going for examining a child
Yes,
suddenly. He is not going to be too friendly with you all of a sudden. So
Yes, sir.
you go by the history. You already mentioned how he is communicating with the parents. If that is satisfactory, you be satisfied.
Yes,
Okay.
sir.
Probably what you are hearing is probably if you find out any dysarthria or any such thing, that may be more objective. Okay.
Yes, sir.
His word output and other things may not be so free with you.
Yes, sir.
And also,
So,
all the
PRC
things
is
may not be
funny.
possible in a 2-year-old, 9-month-old child about orientation,
yes,
about
sir.
place, and okay, you, as far as initially pointed, sir, developmental this thing you correlate for examination.
Yes,
That is
sir.
very important.
And
Okay.
and another thing, if you don't find the child to be speaking, but the parents have reported it, you can put it as reported by the parents in the bracket.
Absolutely.
Okay, sir. I'll continue, sir.
Yeah, yes.
Yes.
When we are silent means that you can continue.
Okay, sir.
Right.
So cranial nerve examination, the olfactory nerve could not be tested, sir, and the optic nerve light reflex was present, sir, both direct and indirect. Third, fourth, and sixth nerves, extraocular movements were full and free. The pupils were around 2.5 mm and symmetrical and normal. Trigeminal nerve, sensations over face were present, sir, on touching, and motor clenching of teeth was normal. Jaw jerk on eliciting was around 1+, sir. Facial nerve examination, the forehead frowning, eyebrow raising was normal. Eye closure was normal bilaterally. Teeth showing was normal. Blowing of cheek was also normal, sir. Nasolabial fold was able to visualize both normal and bilateral sides. Taste sensation, he was not cooperative, sir, over the anterior tooth of the tongue.
So rather than saying nasolabial fold normal, you say symmetrical.
Symmetrical.
Okay,
yes,
that is what we are looking at.
yes, sir.
Right?
Yes,
Okay.
sir.
And
No,
also, instead of saying teeth showing normal, you say there is no
Smile.
deviation noted now
yes,
to
sir.
any particular side.
Okay, sir. And there was no drooping. Vestibulocochlear eighth nerve, the child was able turning to sound and was able to localize which side the sound was coming from. Ninth and 10th nerve, movement was of palate and uvula was normal. The position of uvula was also in the midline. Again, taste sensation was not, the child was not cooperative. 11th cranial nerve, the child was able to turn his neck against resistance. And 12th cranial nerve, protrusion of tongue was normal. There was no obvious wasting, deviation, or dysarthria, sir.
But Sushil,
Yes,
let me tell, if I were you in your position, how I would have narrated the examination of cranial nerves. No?
Yes, sir.
Right. We will go to the first. Cranial nerves. See, the examination of optic nerve has 3 components. Visual acuity. If not acuity, something about vision.
Yes, sir.
Is it not important? Especially so in this case. Right. Then we have to color vision we are not worried about. And the second one is field of vision. That is not very difficult to elicit. Broadly, you can elicit. Broadly. Okay? Not exactly. And then coming to oculomotor nerves, see, from third nerve onwards, it's a good practice to write names of the nerves instead of saying 3, 4, 5, 6. Okay? As long as we are students, at least.
Yes, sir.
Right. See, from third, the oculomotor nerve onwards, it's you are expected to examine for the function or deficit in the function of upper motor neuron and lower motor neuron. It is not for the, yes, Tejaswini, you are right. It is not for the 7th nerve, facial nerve alone, upper motor neuron and lower motor neuron. From third onwards, for every cranial nerve, we are supposed to assess the upper motor and lower motor neuron function. See, for example, oculomotor nerves. What is the upper motor neuron function of the oculomotor nerves? I am putting 3. Nerves means all 3. What is the upper motor neuron? How to elicit? How to assess? Upper motor neuron always decides movements. Yes, Bhargavi, you are right. Upper motor neuron is always decides the movements. That's why the prototype of upper motor dysfunction, that is, as far as we are concerned, cerebral palsy, where there is movement. Okay, for that you look for the conjugate movement of the eyes, right, in different direction, broadly. And that can be elicited, even doll's eye movement can be elicited in comatose child. And coming to the lower motor neuron function, for those oculomotor nerves, first comment about the eyeball position. In this case, it may not be exactly detailed, but when you present the case, the examiner should know how detailedly you have examined position of the eyeball, visual axis. Then you test for the movements in different directions. For all other 10 nerves also, as far as possible, upper motor neuron, lower motor neuron function is to be assessed. Coming to the oculomotor now, after that you have to talk about ptosis. Then comes the pupils. It is the size, equality, then reaction to light, direct and consensual. Let it be a little elaborate for the oculomotor nerves. Next. Right. Okay. Right. We have mentioned about the corneal reflex, conjunctival reflex later.
Sir,
The reflexes.
yes, sir. Superficial reflexes I have mentioned, sir.
Okay. If you have mentioned, need not show it now. And facial now you have to examine from the cephalocaudal. Anywhere examination is cephalocaudal. You have brought out completely. Right. Next.
Would fundus be important?
Sorry.
Yes, sir.
Yes, sir.
Yeah. So either
right.
make a mention about it, either you are not done, or you can simply say it was not done. It reflects that one differential may be missing.
I see. Yes, sir. I have done, sir.
Right. First is position of the uvula, then elevation of the palate. Then the movement is not hair splitting. Don't think that is hair splitting. Elevation. What movement exactly I want to learn? Elevation. Whether it is uniform and equal. Right? And we can talk about something about swallowing difficulties. When the child is either neurologically significantly defective, especially cerebral palsy, don't go for the tickling of the posterior pharyngeal walls. He may vomit or aspirate. Okay. Feeding difficulties. That is something like history, but you will have good idea about the functioning of the ninth nerves. For again, hypoglossal nerve, first talk about the upper motor neuron. That is deficit in the movements when the tongue is put into the action, not at rest. Okay. The deviation or anything occur only when the tongue is put into action. That is protrusion or pushing the speech. Then you talk about the lower motor neuron lesion. That is wasting fasciculations. Okay. I think that will be more comprehensive.
Okay.
In your case, they are not affected, we know, but let it they be complete. Mera, you're right, fasciculations. We'll proceed.
So coming to the motor system, the child's attitude of the limbs were the upper limb and lower limb were normal, sir. Like it was a neutral position. Nutrition wise, the upper limbs, mid upper arm circumference on both sides were 13.5, sir. And mid thigh and mid calf also, there was no major discrepancies. It was almost similar in size. So no obvious wasting was noted, sir. Tone, the child had hypotonia in
No,
the eye.
instead of saying wasting, no obvious difference.
Difference.
Okay.
Okay.
You are not looking for wasting, you are looking for any difference.
Yes, sir. Yes, sir.
Okay.
And child had hypotonia of the right upper limb, sir. Lower limbs were normal and left side, both limbs tone was normal, sir. Power. Yes, sir.
Just I want to, sorry for interruption.
Yes, sir.
It is upper motor neuron lesion, it appears, isn't it?
Yes, sir.
Then what do you expect in upper motor neuron lesion?
Hypertonia, sir.
Hypertonia. Then how do you explain hypotonia? Your explanation is correct.
In neurogenic shock, like post
neuronal shock, initially
shock,
there can be hypotonia. Right, very much. Because
how long do you think it will last? Sushil, yes, how long do you think it will last?
So, few days.
It can go up to even 2 weeks.
Okay, sir.
Okay. He's still in that phase, so it can be hypotonia now.
Okay, sir.
Acceptable.
Again, Dr.
So usually in the exam, you will be asked to demonstrate how you look for hypotonia. Okay. So you should be able to show the maneuvers. So how you make out by observation, then what are the range of movements, how do you test? And then various things like shaking the limbs and looking at the flabbiness around the joints. Those things you'll have to mention. Okay, please remember that.
Okay.
Right.
Yeah.
Coming to tone,
yes,
because
sir.
most of the university colleges, the cerebral palsy is the one which is kept as a long case. Not if not totally for your case, you are expected to examine the tone, assess the tone in the groups of muscles that are subserving a particular function at each joint. See, for power, you have wrote it nicely.
Yes,
tone in the adductors of the shoulder, abductors of the shoulder, flexors of shoulder, extensors of shoulder, and also what are the other movements? 4 I told.
4. Sir.
It's a ball and socket joint. What are the other 2 functions? Before that, rotation, interrotation.
Internal and external rotation.
Mera Tejaswini, right. Okay. Not exactly in your case. Cerebral palsy is mostly given for all the PGs attending. You expect the to describe the tone is hypertonia classically in there in the groups of muscles that are subserving the single function at a particular joint. Okay.
Okay, sir.
So ball and socket joint, at least 6 movements are there. Yes, power.
Yes, sir.
Yes, yes.
Sir, the child had the hand grip was weak on the right hand, sir. Hand grip was good on his left hand. Shoulder power examination, the abduction of shoulder was found to be 4/5 on the right side, and extension of shoulder was also found to be 4/5. Other components were close to normal power, sir. Elbow extension was found to be 4/5 on the right upper limb, and wrist extension was found to be 4/5, sir. Otherwise, the child had normal power in all other movements. Coming to the lower.
Just a minute. Go back. Dr. Chakravarti did a right thing in mentioning about the hand grip. Some of the PGs may post why it is so significant. He's right. Happy that he mentioned about hand grip.
Distal.
What is the significance specifically? Just give 1 minute for the PGs, other PGs. Why hand grip I am appreciating. Before you answer, hand grip is supposed to be one of the vital signs, especially in adults. But in this child, in what way it is more significant and relevant? Dr. Sushil will tell.
Sir, we can assess the distal muscle power. Distal muscle power can be assessed, sir. Involvement of the proximal muscles or the distal muscles. So
yes, yes. When it is neural involvement, he want to further confirm that it is the distal muscles that are more involved. Yes, yes. Right. Karan Bindu Bhagavi Tejaswini, you are right. Okay, that's good. So keep mentioning about the hand grip. Right. Good.
Lower limbs.
Sushil,
Yes,
another thing, because all the PGs are here.
Yes, sir.
So if you are telling so extensively, you should be able to demonstrate. Sometimes the examiners will ask, especially the lower limbs, when you are talking about adductors, abductors, and all, how you are telling exactly 4/5. You should be able to show the movement against gravity. Okay.
Yes.
So you should know how to put the limb to assess the power against gravity.
Yes, sir.
Especially for abductors, adductors, etc. Okay. So you should be looking at some of the clinical methods book and be very thorough about a cooperative child, how to do all this.
Yes, sir.
Yes.
So lower limbs, the power was found to be 4/5 for the hip flexors and knee flexors, along with ankle dorsiflexors. Otherwise, the child had normal power. The coordination, the child was not cooperative, sir, right? But he had no visual gait abnormality at the time of examination, sir.
So if the child is not cooperative, what?
Yes,
see, he may not do the finger nose test and other things. So can you make a comment on the coordination by some observation?
Yes, sir. On handing him a point of an object of interest, if he is able to correctly hold it.
Give him a biscuit
normal child. Yeah. Child's curiosity, how he is picking up things from the ground.
Yes, sir.
Okay. So you don't do it. Let the mother or the father do it.
Yes,
he will
sir.
be more comfortable handling things. Okay.
Yes.
You have to only stand there and observe. Please remember that in pediatric neurological examination, especially less than 5 years or even after that, 1 or 2 minutes just standing back and observing, you will learn more things than doing many of the objective examinations.
Yes, sir.
Okay. Many things like abnormal posture and some jerky movements, myoclonic jerks, all this will get unraveled if you just spend 2-3 minutes. Just don't make the child conscious. Observe in a sneaky manner, but observe.
Yes, sir.
Even when you are taking history, you keep observing what the child is doing.
Okay, sir.
Right.
See,
That'll
give the child a biscuit, he will eat without overshooting or undershooting. That is, it need not be finger nose test always.
Yes, sir. Yes,
okay,
sir.
give her something to eat, and if she is able to put it in the mouth without overshooting, that is coordination is present. Okay,
Yes, sir.
it need not be in the respiratory system, it need not be 99, 99, 1, 2, 3. The cry itself is sufficient. Here also, you give something to eat and whether the child is able to put it without overshooting. That is, coordination is better. Next.
Pediatrician should be opportunistic. Okay.
Right.
The child's
In a right
comfort,
way.
you finish your examination. Yes.
Next.
So coming to the reflexes, sir, superficial reflexes.
No, just go back on the previous one. Gate, you said nil. Would you like to make
sir,
any observation on this?
the child, I had observed for any circumduction gait, sir. The child had no gait abnormality at the time of examination, sir. He was walking towards his father and just a slight hesitancy to walk, but then on prompting, the child was walking well towards his father and away, sir.
Apart from circumduction, what else would you note?
Any dragging noted, sir?
So,
Proximal muscle weakness.
which limb do you think is more affected? The more
Upper limb, sir.
problem?
Upper limb. Upper limb.
So, what will you be looking for when the child is walking?
The swaying of his limbs, sir.
There are associated movements.
Yes, sir.
So if there are paucity of associated movements on that particular side would reflect some weakness.
Yes, sir.
Very, very good point. Very relevant point, sir. That's it.
And what can bring on this? Child is not doing it. I mean, you are not able to make it out on walking. What you can do to bring out this minimal disturbance during the gait? Make the child run.
Okay.
Many a times you will find out during the running, he will assume the typical hemiplegic posture of the upper limb. Okay. Which he may not be doing, sometimes may be missed when he is walking. Of course, all depends on the child's cooperation. He may not run also, that is another story, but you can always attempt.
Yes, sir.
And you can also make him walk up few stairs. You can choose which foot he is playing first.
Okay, sir.
You know?
Yes, sir.
If he's always using the left side to take up, you know that yes, it may be possible.
Okay, sir.
Dr. Ganesh Kulkarni is the national convener for these DG academies. Your inputs, Dr. Ganesh Kulkarni.
Thank you, sir. Thank you.
Right.
Sir, very good evening,
job.
sir. Very good evening.
Right.
Extremely sorry for joining late because this was a Monday and Monday OPD because that was the one biggest hurdle. But the end of the session was too enjoying. I was just listening to each and every word spoken by you. And it was a wonderful case presentation by Vishal also. Sushil, he was doing so great. Ramchandran sir is always inspiring. He's a teacher of teachers. And that's a deadly combination when Ramakrishna sir is with Ramchandran sir. Perhaps the biggest duo. Sir, I really admire the zeal to teach. And this is very inspiring, when I feel when I'll get retired from all this professional practice, this is the way for leading life peacefully and giving back to the society. And that's where, I admire both of you so much. Thank you so much, sir, for being our teacher. We all students need you. That's the only bottom line that I want to say you today.
Thank you, sir. Sir, this thing, I'll just say one thing. I just asked Sushil just one day prior to this thing. He was so ready. See, many of the students also, they sometimes hesitate because big guns, big examiners are coming and what they will think. See, always that hesitation is there. I really appreciate the readiness in which he is doing, sir.
Yes,
thank you for the opportunity given to both of us.
And then this is the time when we were students, we used to be exposed to only teachers who, in our own institute. Now, because of this digital revolution, I feel these students are very blessed to have teachers across the country. And that's the biggest boon that they have.
Absolutely. Thank you, sir. Thanks once again, DAAP.
Thank you so much.
Ganesh.
It's an honor for us to host you.
Right. You are doing wonderful job for DG Academy. Thank you.
Sir.
Right.
Thank you so much, sir. Thank you so much.
So Ganesh is right.
No, see, at this age, even despite his secretaryship and no, Dr. Yogesh Parekh is so keen to join each and every program. That's his greatness.
Yeah,
See,
amazing.
PG
And
program
Dr.
is
Alok,
always,
Dr.
uh,
Srinivasan,
Srinivasan
inspiring
Srinivasan sir is
personalities.
always there. We
sir
all
is
must
our
really
mentor.
thank Srinivasan sir.
Ganesh, sir is always our mentor since last 5-6 years. I am observing sir. Wherever the sir is traveling to US or anywhere, he definitely join at midnight or
Absolutely, absolutely. True, very true.
Inspiring, sir. My teacher, sir.
yeah.
Teacher
Sir,
of all
teacher
teachers.
of all teachers.
Absolutely. Absolutely. Absolutely.
Thank you, sir. Thank you so
Thank you,
much.
Ganesh, for
Yes,
joining.
sir,
Right,
and Ramakrishna sir. Thank you.
right, sir.
Take care, sir. Good night, sir. Good
Right,
night.
good
Right.
night.
Dr. Sushil,
Yes,
I
sir.
will come back to the academy. And you would have mentioned about conjunctival reflex, if not doing carnal. Carnal, I also don't
Yes, sir.
encourage doing when you don't think of it unnecessarily, even putting a swab in. Conjunctival, maybe, at least you mention it,
Okay, sir.
that we know that we have to do all those things, right?
Okay, sir.
Doesn't matter even if you don't do, but the examiner shall know that you are aware of the particular heading you are expected to do. So don't miss the headings, especially in the CNS.
Okay,
The
sir.
examiner should be knowing that you know what to
Yes.
examine. Okay, that's the right.
Uh, sir, yes, sir. Plantar reflex was elicited, sir. It was more of a withdrawal sort of a reflex on the right lower limb. Left was intact flexion. And
So withdrawal, you feel it because it's a bit sensitive.
yes, sir. When I kept itself, he was
So can you do some plantar equivalents? Any other maneuver you could have? You could have tried?
yes, sir. The Achilles tendon, I could have pinched.
Yeah.
And
Right.
the calf muscle, I could have
Yes.
given
Squeezing
pressure,
the calf
squeezing
muscle
the calf.
and shin pressure.
Yes, sir.
See, some children are, you're right. You're right. They are a bit sensitive. The minute you touch the sole, they will this thing. So the other things they may not mind. Just on the giving a pressure on the shin and taking it down. Sometimes you may be able to identify. Okay.
Yes,
When it is
yes.
not coming regularly by the regular examination, you can make use of these maneuvers.
Okay, sir.
Right.
The deep reflexes were present on both sides bilaterally.
Present and normal.
No, you have to mention that also. Present is different and normal are not.
Yes, sir.
Yeah.
Present
That you have to
and
mention. Okay.
okay, sir.
It is your impression only. You say present and normal. Okay.
Okay, sir. Present and normal in all.
Yeah.
Sir,
What are you
bilateral.
expecting? What are you expecting?
Sir, if in ischemic and stroke, it could be exaggerated, sir.
No, don't
So,
forget
yeah,
about
that's
what is
why
the primary cause. Corticospinal
yeah,
tract involvement
how
in
about
4-5
etiology?
days, what do you expect?
Sir,
Yes.
no, sir, nil reflexes here. Air
So
You
it
reflex,
is
yeah.
related to tone.
think I
When
exaggerated?
there is hypotonia, you don't expect
Air reflex,
exaggerated
yeah. Yes, sir.
Okay.
Air reflex.
Not a reflexia, decreased.
Hypo, sir.
Is it always, do they go together, Sushil? Hypotonia and the tone and reflex?
Not necessarily, sir.
Not necessary, no? See, yeah. See, sometimes the tone can take a longer time, the reflexes may become brisk. So always, it is possible that they may not exactly go together. So you elicit both of them. So
Okay, sir.
it's important. You heard of hypotonic cerebral palsy. That
Yes,
time,
sir.
one of the points which mentioned is hypotonia will be there, but the reflexes will be brisk.
Brisk.
Brisk, right, sir.
Okay.
Right, sir.
Yeah.
Well taken.
Yes.
Well taken.
Yeah.
Right.
Go ahead.
Next.
Sir, sensory system, superficial senses, the touch and pain was intact on both the right and left side, sir. Temperature differences, the child couldn't tell whether it was warm or cold, so I wasn't able to elicit properly, sir. Deep pressure that was
Sushil,
intact.
again
Yes,
be
sir.
practical. Sushil,
Yes, sir.
again be practical in the
Yes, sir.
exam. Okay. You do not have to make a child subject to a painful stimulus.
Yes.
And such a 2.5-year-old child, even touch, how much he will be able to appreciate. Okay.
Okay.
May be difficult. You can just take the parents' history.
Okay.
You can tell that the parents say that he is able to feel some insect bite or other things or something touching. He is able to feel. Okay. You don't want the child to be subjected to any uncomfortable thing. You can make use of it. Ultimately, you want to know what is actually happening.
Yes, sir.
That's all.
Yes, sir.
We are not dealing with adults. Yes.
And
Go ahead.
moreover, when you are talking about a higher mental, I think a cortical dysfunction,
Yes, sir.
which kind of sensations are you thinking would be affected?
Sir, cortical sensations would be more affected than the.
No. I'm talking about your sensory systems. Which cortical sensations would be there, which you can actually demonstrate with such a child?
Sir, tactile localization.
Anything else?
Stereognosis.
So the child has to understand your instructions.
Yes, sir.
And if yes, that level of comprehension is there in the child, only then you can ask her to demonstrate.
Yes, sir.
So if the child is not able to understand your instructions, probably the test will not come through.
Yes, sir.
Right. We'll proceed.
Cerebellar system examination, there was no nystagmus. Nystagmus was absent. Scanning of speech was absent from the parents' history. Hypotonia was also, the right side was noted, sir. And intentional tremor was absent, sir. On asking the child to pick an object of interest, he had no tremulousness in the hand. Rebound phenomena was not noted. Titubation was not noted. Pendular knee jerk was absent, and there was no cerebellar gait. Skull and spine, there was no meningeal signs and no neck stiffness. Karnick-Brzezinski and straight leg rising test were absent. Fundus examination was done, sir, and it showed no signs of papilla edema.
How were the carotids, Sushil?
Sir, carotids were felt bilaterally and equal, sir. Both carotid boxes.
You are coming to that later. I'm sorry. Right. Sorry. Yeah, generally fundus can be mentioned here, but generally in the second nerve itself, as I was asking,
okay,
you could have
Part
of the second nerve examination.
Okay,
you could have completed fundus.
Either way, it's okay.
Yeah.
Right.
Go ahead.
Proceed.
Sir, other system examination, CVS, S1, S2 was.
Here, just to save time,
Yes, sir.
The one particular point you have mentioned very aptly. What is it? Any PG, you comment. One sentence I would like to know. The next sentence. I like to appreciate Dr. Chakravarti. What is that sentence? Anybody? Okay. It is bilateral. Carotid pulses are felt normally and equally, not normally also. Not
Okay,
it,
sir.
it may be lower on both sides. Normally and equally. Why? Why it is a point to be mentioned?
Sir, again, any thromboembolic manifestation within the carotid pulse at dissection, or the internal carotid artery, trauma related also can occur, sir. So we have to make sure that we are ruling out that.
Right. See, the cerebral flow is normal to the brain. Broadly, we can arrive at. Okay. Right.
Okay.
Next.
So coming to the summary of the case, this 2-year-old right-handed male child who
You can modify also, Sushil. You need not
Yes.
read this alone. If the inputs given, you can modify also.
Yes, sir. A right-handed 2-year, 9-month-old male child presented with
Previously normal male
previously normal male.
Developmentally normal child. Right.
Yes, sir. Previously
very nice.
developmentally and
Yes, sir.
neurologically
I'll take
normal child presented with acute right-sided hemiparesis with human type of facial palsy and motor aphasia with lesion probably at the level of the cortex and with having no known medical comorbidities with positive significant history of varicella infection 3 months prior to current illness, probably pointing towards vascular etiology, which is
Be specific. Why vascular? Is it arterial or venous? You be specific.
Arterial involvement due to post varicella angiopathy, sir.
Okay. Anything else you would like to do? Just we'll stop here.
Yes.
And okay, you tell about provisional diagnosis, right?
Sir, the provisional diagnosis, it's acute right hemiparesis with UMN type of facial nerve involvement with motor aphasia, lesion at the level of cortex, probably arterial etiology, vascular etiology involving artery, anterior circulation component, sir. Differentials, post-varicella and angiopathy comes first, and other vascular etiologies follow, sir. And otherwise, stroke mimics like Todd's palsy, space occupying lesions, hemiplegic migraine, renal trauma can cause such presentations.
Yeah. See, when it is facial nerve is upper motor neuron palsy,
Yes,
it is
sir.
part of the hemiparesis. We need not specifically mention. Nothing wrong in mentioning.
Okay,
You may say vascular. You may put it as arteriopathy.
Okay, sir.
Okay. Why vascularity? Be more specific. Say clinical diagnosis. Better say clinical diagnosis rather than provisional. Your clinical diagnosis, you are confident that will be the final diagnosis. Don't say provisional, clinical. See, you say arteriopathy because of varicella infection 3 months prior. Okay, before going to different diagnosis, comments from Dr. Balasubramanian. Dr. Balasubramanian.
The provisional diagnosis as motor aphasia. What is motor aphasia? How did you make a diagnosis of motor aphasia?
Sir, the child had just decrease in speech output, sir, but he was able to understand what the parents or I was trying to convey to him, and so I felt I feel it is motor aphasia, sir.
Is he speaking or not?
He's now at the point of examination, one word, sir, like 1 or 2 words alone he was telling, sir, but it was not up to what his developmental thing was, sir. His normal development was, sir.
Okay. Is it aphasia or dysphasia? What he has got?
Now
what is the difference between aphasia and dysphasia? You think he has got dysphasia or aphasia?
So now dysphasia, sir.
Pardon?
Currently dysphasia, sir.
I think you should have used instead of using the term aphasia, the correct terminology might have been dysphasia.
Okay.
That's my comment number 1.
Okay, sir.
Second is, you are saying probable vascular etiology. Why are you saying probable? That means you're not sure. Is it venous?
No, sir, arterial.
Huh?
Arterial.
Straight away you could have said it is arterial.
Yes, sir.
And again you have put it as anterior circulation. Is he having a dense hemiparesis or a very patchy hemiparesis?
Sir, patchy, sir. Right upper limb was involved more than the lower limb, sir.
That's what you expect. Obviously, in any hemiplegia, the upper limbs will be more affected than lower limbs. That's a rule. That's a rule in hemiplegia. Do you think this looks like a dense hemiparesis? You have involvement of the speech. Okay, you have involvement of the upper limb and lower limb.
Okay.
The thing is, he seems to be recovering.
Yes, sir.
Have had a dense hemiparesis and he is recovering.
Okay.
Speech involvement, dense hemiparesis. You still want to say it is anterior circulation, or where is the lesion? Which part of the brain is involved? Is there a lesion in the frontal cortex?
No, sir.
Parietal cortex? Temporal cortex? Where is the lesion in this boy? Or it is subcortical?
Parietal, I feel, sir. If it is dense, subcortical.
Could it be internal capsule?
Yes, sir. Dense hemiplegia
It could well be in the internal capsule. I don't think this is simply in the frontal cortex. This is likely to be localized to the internal capsular lesion.
Yes.
Okay, he seems to be recovering.
Okay, sir.
In the differential diagnosis, the first diagnosis you have put as young stroke. What does the terminology mean, young stroke? Is there any
Sir.
terminology called young stroke?
Less than 40 years.
I don't think. Sir, Ramakrishna sir, is there a term? PRC, is there a term called young stroke?
Yes, sir. Yes, sir. They use the term stroke in young. If it anything less than 40 years.
But in pediatric, it's a pediatric stroke.
Yeah, it's pediatric.
As adult physicians use
Yeah,
the
stroke. You can say stroke in a child.
yeah, stroke. This is a pediatric stroke. Okay.
Okay, sir.
Okay, vascular agreed. Post varicella vasculopathy or angiopathy very much agreed. In the differential diagnosis, you have put ADEM first. Why? And how do you defend yourself? Is this ADEM?
Less likely, sir. Child had no alteration in
Most
behavior.
unlikely. Why most unlikely?
No alteration in behavior or seizures.
Absolutely. So I wouldn't put that as a, which is the, you see, you are given so many other differential diagnoses. Okay, other than the pediatric stroke, post varicella vasculopathy. Okay.
Yes, sir.
Now I'm going to ask you a different question, exam question. What are the commonest causes of stroke, pediatric stroke in India? In Indian children, what are the most common causes of pediatric stroke?
My congenital causes.
Congenital cause. Which congenital cause?
Sir, any metabolic disorders?
No. Common.
No. There, I asked you common. I mean, just asking a Viva question in the exam. Common causes of pediatric stroke in India. My question is very specific.
Sir,
Dr. Bala, I would like to add a little additional part in that question.
No problem.
Right. In that scenario, the incidence of hemiparesis stroke is 400 times higher. Probably, sir, you are referring to that only? Right. The incidence of stroke is 400 times higher. What is that condition? About which you have not mentioned in the general examination or history. What is the scenario where the stroke incidence is 400 times higher than any normal child? What is that condition? Anybody? This is a common condition. No? Anybody? Sickle cell disease.
Sickle cell.
Yes, Dr. Hemaja, you are right. Madhni, Ramya, you are right. In sickle cell disease, the incidence of stroke is 400 times high. Okay, that you have to make some inquiry in the history and general examination. You answered Dr. Bala's question.
Yeah, I mean, the answer that any examiner would expect will be 4. I'm trying to help exam going students. Number 1 is intracranial infection. Okay. Intracranial infection, bacterial tuberculosis. Okay, 1. Number 2 is heart disease, congenital heart disease. Particularly cyanotic congenital heart disease is not treated at the right time. Number 3, trauma, whether it is, neglect of the child, road traffic accident, right? That is number 3. Number 4, preventable cause, easily preventable cause. Can you give me 2 preventable causes for stroke, pediatric stroke in India? Most important pediatric stroke prevention measures. Can anybody put in the chat box 2 most easily preventable stroke etiologies? Diarrheal dehydration.
Yes, sweetie, right.
Diarrheal dehydration, iron deficiency anemia. Okay, so these are the 4 answers an examiner might expect with this reference to India. In fact, you'll be surprised in the literature in the 1990s and 2000, most reported series of strokes in India were due to congenital heart disease followed by trauma. Now I think with more interventions happening in the society, I'm sure that group is coming down. The cardiac group. We are now operating on many children with facilities being made available for poor children also across the community. Okay, with ORS and reduction in the diarrhea due to rotaviral vaccine, even the diarrheal disorders will become uncommon causes of stroke, causing venous thrombosis or stroke. Okay, that's one. And third, thoughts paralysis. Do you think this is thoughts paralysis?
No, sir.
Why?
Sir, no seizure history, sir. And also it took more than 24 hours. Like the recovery period was a little bit prolonged, sir. Rather than
Usually they recover in 24 to 72 hours. Okay.
yes, sir.
The next thing, you have put hemiplegic migraine.
Yes, sir.
2.5-year-old child.
Headache itself.
2.5-year-old child.
Won't
I'll
present.
strike it off. I'll strike it off.
Okay, sir.
I will strike it off. I'll strike it off. 2.5-year-old child, no hemiplegia. It's usually older children.
Okay, sir.
Okay. Press. Why did you put?
Sir, hypertension causing.
There is no hypertension in this child at all. Nothing renal happening. Again, it's out. No visual disturbance.
Yes,
Out.
sir.
Trauma, there is no history, so it's all out.
Okay, sir.
Tell me a few other differential diagnoses other than one diagnosis you have not put. I mean, you have put space occupying lesion. Where
Yes,
is the lesion? What lesion do you expect?
Sir, involving the some bleed, sir, in the subarachnoid or EDH.
No. Which space occupying lesion are you thinking of in this scenario? Which space occupying lesion? You have put SOL. Which space occupying lesion do you expect? 2.5-year-old.
Subdural.
No, not subdural. No history of trauma. Yeah? You're not going to think of subdural hematoma unless there is a trauma.
Sir, any looking?
Any malignant tumor can present exactly like this, insidiously, without fever. It is not ruled out in this child, even though there is a history of varicella. A slowly growing is not completely ruled out. In fact, I would even say even a cerebral abscess is not ruled out. You may not have fever. It can present exactly like this. And of course, in an older child, tell me one other diagnosis, some infectious disease, presentation like this. Parasitic disease.
Neurocysticercosis.
Can very well present like this. Space occupying lesion, neurocysticercosis are all things. However rare they should be considered. Okay.
Okay, sir.
These are my thoughts at this point of time. And in all probability, this is mostly a post-varicella vasculopathy with the recovering. In fact, you could have mentioned that this child is recovering in the diagnosis.
Yes, sir.
Recovering or improving.
Yes, sir.
Okay.
Yes, sir.
Over. Thank you.
Thank you, sir.
See, the diagnosis
Sushil,
fully reflects the
Sushil?
status of the child.
Yes, sir.
Sushil, if this varicella history was not there, what do you think of? No heart disease, nothing to suggest cortical venous thrombosis.
Yes, sir. And
So what else? What will you think of?
Any bleeding manifestations, sir, or arteritis, autoimmune pathologies.
See, you have to think of another condition when there is no obvious cause. It's a thrombotic state. Sometimes some of these conditions are procoagulant state. Okay, they may be having some of these inherited problems.
Protein C.
You have heard of many such things. No, protein C,
Yes,
protein
sir,
L,
protein
they say
C,
all
protein.
this. That
Yes,
is
sir.
what they generally do the testing also.
Yes, sir.
Okay. And newly they are also talking about some conditions like
Melas.
where there is localized arteriopathy, okay, cortical areas, some localized areas, there may be some vascular changes. Actually, they find some genetic association also for this. Okay, these are all the things where there will be no identifiable clue.
Okay.
They just present with hemiparesis. Once you do the testing, only then you may come to know about it. The another thing I'd like to mention is, instead of saying motor this thing
Yes.
aphasia, probably better thing will be expressive aphasia.
Okay, sir.
Okay. It's not a receptive aphasia, it is an expressive
Expressive
aphasia
aphasia.
or dysphasia. That would have been better. Okay.
Okay, sir.
And you're though technically correct to say anterior circulation. What do you mean anterior circulation is anterior
Both
cerebral
anterior
and middle
and middle
cerebral artery.
cerebral.
Yeah. Instead of that, you can make it very specific that it's a middle
Middle
cerebral artery,
cerebral.
probably a middle cerebral artery involvement. Okay.
Yes, sir.
So that makes it much more clearer.
Okay, sir.
So these are a few comments. Okay. Sir, Dr. Ramakrishna, you can take it.
Right. We'll proceed, sir. Right. Yes, Ashil, any more? Okay.
Upon receiving, sir, we had the child was started on aspirin.
Sir, do you want to know, sir, what is this thing? Or can you present what has happened to the child?
Briefly, because everybody is interested to know how the treatment goes and how is the further recovery and what is the prevention.
Yes, sir. Right. Upon receiving in the PICU, the child was started on anticoagulants, sir. After sending the basic after sending investigations which were needed, aspirin was started at 3 mg per kg per dose and was continued throughout the stay in the hospital. Otherwise, conservative management with close monitoring for any new symptoms or worsening of the persisting symptoms were done. Rehabilitation wise, the child was initiated on physiotherapy, occupational speech, and swallowing therapy, along with educating the parents regarding home-based care for the same. Pediatric neurologist opinion was obtained and at the point of admission itself, and was advised to do an MRI brain with MRA and 2D echo, along with investigations like the CBC, ESR, CRP, ferritin, all these for ruling out the etiopathogenic cause. And also we to send the protein C is antithrombin factor 5 homocysteine after 3 months, like after the acute phase has settled. After 3 months of the presentation, so that we can get a significant hit. And if homocysteine was elevated, we were advised to do serum folate, B12 levels, and to look for metatetrahydrofolate receptor mutations. And also CSF samples were sent for varicella PCR, antibodies, and basic biochemistry, sir. Investigations.
You can skip this.
Anything abnormal, you tell.
Okay, sir.
Not go through.
Yes, sir. Investigation
next slide.
was okay, sir. Only
any abnormality you tell. Otherwise, we'll skip.
Yes, sir. Triglycerides alone, there was spikes, sir. Otherwise, LDL, HDL was within normal limits. We are yet awaiting factor V Leiden and APLA results, and the CSF samples have been taken yesterday late night, sir. So we are awaiting the antibodies for varicella.
So we have asked the parents to do their lipid profile also, and we will follow it up, sir.
Yes, sir.
So prothrombotic conditions you want to do.
Okay. Yes, sir. Right. And we had significant finding in the imaging, sir. The child had non-hemorrhagic infarcts in the left frontoparietal, parieto-temporal, and basal ganglial regions along the corticospinal tract, and also a chronic infarct in the caudate nuclei, sir. And there was occlusion or a thrombus in the distal M2 segment of left middle cerebral artery, and absent flow-related signal intensities in the M2, M3, and M4 segments of middle cerebral artery, sir. The varicella, post-varicella angiopathy, according to studies, also showed some similar findings in the M1, M2 segments. There were found to be abnormalities, sir.
Sushil, in an acute... Would you like to tell us, enlighten us, what could be the reason for chronic infarcts, as you think? Do you think there is some other condition contributing to this thrombosis? Probably, I'm talking, because they are mentioning specifically chronic infarcts.
That's why we would like to rule out any procoagulant state, sir. Since it's acute state, we are not able to do those things. We are planning to do it after 6 to 8 weeks time.
That's right.
And this thing which was triglyceride, which was found to be higher in the child, we want to do the parents and also repeat it in the child to find that whether it is a one-off finding or is persistently.
That's good. That's good.
Dr. Sushil, this
Yes,
in
sir.
case this child was improving,
Yes,
but
sir.
in case you encounter a child with acute stroke, which is the preferred imaging you will, the CT scan or MRI?
Sir, MRI is preferred, sir, because acute infarcts will be able to pick up more, sir. The ischemic penumbra and the acute start of the infarct site, sir, rather than a CT which would show a late finding, sir.
No, anyone else from the residents?
Hemorrhagic to
Sir
rule
has
out
tell
CT.
very clearly, acute.
Sir, to rule out hemorrhagic initial CT, we will do, sir.
Yes, that is precisely it. Because it's an urgent intervention if it's an hemorrhagic thing. So MRI will pick up anything, yeah. But in an acute stroke, you have to rule out it's a hemorrhagic or not. CT is the one which will pick it up.
Okay, sir.
Not MRI will miss hemorrhage.
Yes, sir.
So there is a
There
question
is
for
a
you. Would you
question,
like to
another
start
question in the
anti-epileptic?
chat box.
Anti-epileptic drugs, would you like to start, Sushil? Somebody
Sir,
is asking.
no, sir. We
No,
find
Dr. Tanvir is asking.
no signs of any increased intracranial tension, no fever history, no encephalitis, and also no previous history of seizures, sir. So we can wait on anti-epileptics, sir.
How will you counsel the parents?
Sir, we have to explain them the current status of the child and also that this situation might require a long-term follow-up and on finding what the exact etiology is. So we might not get concrete evidence at the initial stage. We might have to take it step by step, and then physiotherapy is more as much as important as the medications that we are going to give, sir. And
they may ask you whether it will recur.
Yes, sir. There are conditions. Most of the conditions will recover, sir.
No, recur.
No. Recur.
Recurrence is there, sir. There is a high chance for recurrence in the future, sir.
So recurrence can occur in which situations?
Any insults, sir, further like noxious, neurological noxious stimuli. Or any prothrombotic states induced like iron deficiency anemia or another trauma, such conditions can aggravate and produce a stroke, sir.
So previously all the unoperated cardiac diseases used to get recurrence.
Yes.
Okay. So
and they can be alternate also. Other limb can be involved.
Okay,
coming next one.
Okay, sir.
So that is actually a genetic condition also where you can get alternate or recurrent hemiplegia. So if you get like this, then you may have to do some genetic studies also.
Okay, sir.
Dr. Alok, you may unmute and ask verbally, right? We are in that stage, right?
Thank you, sir. The child was vaccinated by NIP, so varicella vaccine was not given for sure.
Yes, sir. Yes, sir.
But we do encounter breakthrough varicella after 1 or 2 doses. 2 days back, I had breakthrough varicella after 2 doses of vaccines, which were administered by me on myself in a 14-year-old child. But do breakthrough varicella will encounter such arterial complications?
Sir, they could, sir, but it is more protective when the child has antibodies against the illness, sir. I'm unsure about the exact status.
Dr. Alok,
Yes,
your question is thought-provoking, but I'm afraid, of course, one has to look for answers in the literature. The number of cases of breakthrough varicella is so few, but I don't think we have data on breakthrough varicella causing angiopathy. What is interesting is that varicella angiopathy can occur up to 11 months to 1 year following the infection. And I remember reading an article way back, 15 years back in Medicine Journal, American Journal of Medicine, is one of the most common unrecognized causes of post-viral complications due to chickenpox. we may miss the diagnosis because of history we may not elicit, and varicella can be mild. So regarding the breakthrough varicella causing stroke, I don't think there is data. Maybe we'll look up. If I find something, I'll certainly mail you the article if there is anything. I don't think there is any data on it specifically on varicella. But what is interesting is that even in a conservative society like the United Kingdom, where they have not been giving varicella vaccine, they have now this year they have introduced varicella vaccine as part of the NHS schedule. And varicella is a disease which can be fatal. In the sense, varicella can cause toxic shock syndrome due to streptococcus or staphylococcus from the skin infection. Varicella can cause severe hemorrhagic pneumonia, stroke. Okay, varicella can lead to Reye syndrome. All itis can occur following varicella. It's not always a benign disease. It's not always a benign disease. And maybe 5-10 years from now, India also will introduce universal varicella vaccination with 2 doses. And with 2 doses, the protection rate is nearly 95 to 98%. Breakthrough is extremely rare.
Yes, sir. Right. Thank you, sir.
I request Professor Sitaraman to switch on the video and give your final inputs. Professor Sitaraman, please switch on your video.
I'm totally in a relaxed condition, so I'm not going to switch on my video.
Okay, that's okay. Piece of advice for youngsters.
It's a very, very good effort by Dr. Sushil. And I must say the comments by all our teachers have been so clear and crisp. And I think most of the postgraduates will be happy to listen to these corrections which have been done, which are very, very commonly encountered points which examiners notice during their presentation in the exams. And I'm quite happy the way it has gone forward. I think this is one of the first ones I am attending as a PG, this thing. And I think I'm really enthralled. Tempted me to continue attending more of these. Thank you.
Nice of you, sir. Thank you. Dr. Bala, 1 or 2 lines. Beyond subject.
Beyond subject, excellent presentation, Sushil. You will get a medal if you present like this in the exam. Of course, we people like PRC and me, we always interrogate like police constables using a Lathi chart to get the best of it. Okay, fantastic presentation. Excellent case, choice of case by none other than PRC. Good discussion. And this is a very common exam case. And PG should be thorough with everything with regard to pediatric stroke. Use this session as an opportunity to go and read Nelson's textbook properly with regard to pediatric stroke and update themselves. That's more than enough. Of course, clinical illustration of clinical science is important. Please go and refresh. And don't examine nervous system in children like you try to examine in adults. Please adjust. As history, physical examination, everything is different in pediatrics. So get you adapted to the pediatric changes. Thank you. Well done, Sushil.
Just one more point, Dr. Ramakrishnan, just one more point.
Right.
Yeah, one point here, just one more.
Yes,
I always find it beneficial for the residents to go and attend a muscle charting class by a physiotherapist. They'll do the assessment of muscle charting so quickly, on the power assessment, that you are able to make it out very easily. How to keep the limbs and whether to rule out gravity or not. And that they do in a very, fast work. So if you have a good, pediatric physiotherapist around with you, neurology, he'll be able to guide you. Do attend that class too.
Sir, actually, when we were doing PG, 2 weeks posting used to be there, sir.
Correct.
That's precisely the point. Yeah.
Yeah, PRC, just one final comment. I think Sushil said the plantar is withdrawal. It will be withdrawal if Sushil elicits it. If PRC elicits, it will be extensor. I can take a bet with you.
Right. Very true, sir. Dr. Srinivasan. Dr. S. Srinivasan. He was former director of JIPMER, for those who don't know. He is the youngest of all. Then comes Dr. Bala and Dr. PRC. They are the youngest lot in the group. Dr. Srinivasan.
Thank you, sir.
Right. Dr. Alok Gupta, one sentence.
No, it was an excellent case presentation, and it was entirely new situation with post-varicella complication occurring 3 months later than the infection. It's not so common, and definitely, I think routinely we are in general practice, even in the IPDs, we are missing out on a detailed immunization history and not taking history very in detail and not correlating with the provisional diagnosis. So we should be more like, see, I would give an example of influenza. So when we diagnose influenza, we do not, in our case, we don't take a influenza vaccine history. And we don't know the basic effectiveness of the vaccine in the field. So vaccination history in pediatrics, I guess, should be detailed as a part of vaccination history, and that should be used to correlate the illness and the protection affected by the vaccine or the failure by the vaccine should be documented. Thank you, sir.
Dr. Sushil, it was a very good presentation. You are very confident in handling the questions by at least 5-6 people who are stalwarts. Right. You are very confident, assertive, and you have done a good job. And you are, I'm sure that you will come out with flying colors in your exam and career. Now it is the turn of the hero of the session, Dr. PRC, for final comments.
Thanks, Professor Ramakrishna, and all the seniors. First of all, thank CAAP, the whole CAAP president, secretary, and all the people in the OB and EB, and the people who are organizing this wonderful, very useful program. So, two things I will just mention here. First, when Dr. Ramakrishna asked me, I thought it will be myself, Dr. Ramakrishna, Sushil, and a few PGs. I never knew such stalwarts will be here, and they will be listening, they will be analyzing, they will be asking questions. I don't know, Sushil also would not have been knowing about it. Okay. So anyway, he was able to answer well, and I'm also very happy that he got exposure to such probably 5 or 6 examiners at the same time. That is a wonderful opportunity and also a very great learning experience. It was a learning experience for me also. So I must thank the platform for this opportunity to both Sushil and me. The second thing is, I didn't ask Sushil so many questions when he just showed me, because I thought let him present and let it be more spontaneous. Whatever the queries come, let it be as it is, as it happens in an exam, so that it will be more useful for him to correct himself and to improve himself. So that's why we just made it as it is. Whatever he's in the second year, I'm sure he will pick up very well, and he has done courageously and wonderfully well. Thanks to the encouragement shown by all the seniors and the colleagues. Thanks once again, IAP and Professor Ramakrishna.
Right, sir. You are right, sir. In the exam, anyway, you cannot modify him. So you expose him to the externals as you will do in the exams. Right.
Yes.
Right, sir. Thank you. Dr. Tanveer Begum, one sentence. Dr. Tanveer Begum, Professor Tanveer Begum. Yes, you may unmute and speak, Dr. Tanveer Begum. She is professor in Guttur Medical College. You may unmute, Dr. Tanveer.
Yes, sir. Good evening, sir. Thank you, sir. That was an excellent presentation by Sushil. And thank you, Ramakrishna, sir. You are bringing nice cases onto Digi platform. And it's an honor to be, to listen to you all stalwarts, sir. Bala, sir, thank you so much for all your input, sir. Thank you.
Nice. And Dr. PRC, there are many people who have joined in Digi app. It is not the total presence. Okay. Right. Sometime back.
I'm
we
from
did 1 month
Katuri
back.
Medical College, sir.
Right, sir.
You're in Katuri. Sorry.
Yes, sir.
I I would like to mention at this stage that Dr. Sitaraman sir has been my senior registrar in my PG days, and he is my mentor. So I would like to thank him from the bottom of my heart.
My.
Right.
Thanks, Alok. But I must also congratulate Sushil to have kept us a brave front, been examined by 5 to 6 externals from different areas. You know,
Definitely.
But
wish-
Sushil, don't feel hurt that
No,
we
no,
are
sir.
harsh. We
No,
want
sir.
to
No,
prepare
no.
you for the harshest examiner, external
No.
examiner, not
Yes,
to
sir.
discourage you, to bring out the best from you. Right?
Yes,
No, Dr.
But
Sushil,
PRC sir also. It is
Dr.
not about
Sushil,
your
I-
mentorship. We want to be like this so that we can bring out more points for the benefit of all the attendees. Thank you very much, sir. Professor
Thank you.
Ramchandran, a stalwart,
Thank you, sir.
fine, and a
Thank you, sir.
clinician and wonderful teacher for enlightening us. Thank you.
Thank you.
And thanks all
Thank you.
the
Thank
people
you.
who joined. The postgraduates have responded wonderfully. There were nearly 100 responses in the chat box. And I thank all the wonderful teachers who have contributed. We'll say goodbye and all
Thank
the
you.
best to the youngsters.
Thank you.
Good night.
Thank
Thank you,
you,
sir.
sir.
Good night.
Thank
good
you,
night.
sir.
Good night.
Thank you.